Welcome, I'm Dr. Rose Knapp. I'm the director of the Master's Program and the Nurse Practitioner Program at Monmouth University. I'm also an acute care nurse practitioner. I practice with practice experience in the emergency department and currently practice in primary care. I'm also a professor of pharmacology. The purpose of this module is to familiarize you with the pharmacodynamics and therapeutics of opioid medications, giving you some strategies to optimize the benefits of opioid prescribing and reducing the possible risk factors while also being cognizant of any substance abuse issues with patients, and also to familiarize you with current New Jersey law of being a prescriber and a provider. So let's get started. The DEA in the 70s became the regulatory agency of controlled substances because more and more providers and government agencies were seeing more substance abuse. So they started to classify controlled substances, and the classifications are controlled substance 1 through 5. 1 being the most potential for addiction, and then 5 being the least potential for addiction. I would recommend that you look at the 2 sites there. One is the DEA website, which actually is continually updated on the drugs that are issues with substance abuse and gives you more information about the controlled substances. The other one is the CDC website, which actually talks about overdose and substance abuse. So I would appreciate that you would take some time and look at both of those websites. So in the 70s, the substance abuse and controlled substances were actually classified. So if you can look at Schedule 1 is medications that are the most highly addictive, which would be heroin, LSD, marijuana, and right now the laws in New Jersey and federal regulations, depending upon the state, we can now, providers can prescribe medicinal marijuana. In the state of New Jersey, we only have 4 dispensaries presently, and they're in the middle of being up and running. Unfortunately, APNs are not on that law, so we are not covered and cannot prescribe medicinal marijuana at this time. Schedule 2 is the most concerning of the classifications because that's where your opioids are, your morphine, your oxycodone, hydrocodone, DILAUDID, and we have to be very, very specifically regulated on that. APNs can prescribe from Schedule 2 to Schedule 5. The prescribing regulations have significantly changed. We used to be able to fax in prescriptions or call in prescriptions. Now, any controlled substance, even down to Schedule 5, is highly regulated and has to be a written prescription, has to be within 30 days, or the pharmacies will not honor it. So the regulation and the monitoring of these prescriptions are much higher than they used to be. So it's very, very difficult. The patient does have to come and see you and get an actual prescription. I think the thing that's really important to look at is the challenges of pain management, and it's very pervasive right now. You see a lot in the news about pain and pain management. So as a provider and a prescriber, it's really important that you identify what's going on in society in terms of pain. So patients have either acute pain. Acute pain is defined as less than 30 days. Associated with acute pain is that there's tissue death going on. So it's usually a very, very intermittent episodic issue. But chronic pain is the issue that's really most providers are mostly challenged with. And in this last statistics is that about 70 million people suffer from chronic pain for whatever the etiology is. And it actually costs about almost $300 billion in direct and indirect costs. So we really, really need to address this besides the addiction issue, but dealing with chronic pain. And now we're going to look at the American Chronic Pain Association website. And it really does talk about this issue, how to deal with chronic pain. And chronic pain can be anything from somebody with acute back pain to somebody who's going through cancer treatment. So it really all falls into the same thing. So once again, I would ask that you look at that website and really explore it to see what all the, not only the statistics of chronic pain, and also some of the modalities that you can use in treating your patients who have chronic pain. Interestingly enough, almost 50% of patients change providers because they feel that they don't get adequate pain relief. The literature actually discusses that they're not quite sure if people are not really describing their pain adequately, or if the provider themselves are not asking the correct questions. Also to bear in mind is that we do have biases about patients with pain, particularly chronic pain. Chronic pain patients a lot of times are not believed because people feel that, why isn't this going away? And many times providers are viewing the patients as pain-seeking and narcotic-seeking. So we do have to do a better job of assessing our patients' pain. If you ask patients who are cancer patients, they found that only about 70% of them felt that they got adequate pain relief in palliative care, which is very sad. And another statistic that is also very interesting is that people of certain ethnic backgrounds, like African Americans and Hispanic Americans, felt that they received inferior pain treatment because of their ethnicity. So these are all very important statistics to keep in mind when you're dealing with different populations. Pain is defined in many ways, but can be also looked at what the physiological origin is of the pain, the duration of the pain. Also, we can induce pain in patients by procedures. Did they have an injury? Is there an underlying pathology? So it's really important, back to patients who feel that their pain wasn't very well managed, it's important as the provider to ask the particular questions and elicit an excellent review of systems and history. What modalities the patient used before, was there any injury, any associated symptoms, and one always has to be able to elicit a history that really is inclusive to be able to adequately manage somebody's pain. When assessing a patient's pain, we have to also consider the source of the pain and the pathophysiology of the pain. Most pain is somatic or visceral, which has to do with injury to either tissue or organs. The pain that's really difficult to manage as a provider is the neurogenic pain, because usually it's an irritation of the nerve root, and most pain relievers don't really help that, and we'll be discussing some modalities that you can use. And then we have to also consider pain that's related to cancer and metastasis. The World Health Organization has come up with wonderful guidelines for managing cancer pain, and actually it's now being used for orthopedic pain and actually anybody with chronic pain. So if pain occurs, there can be a prompt oral administration of drugs in the following order: non-opioid, then as necessary, mild opioid, which would be codeine, then strong opioids such as morphine until the patient is free of pain. To calm fears and anxiety, additional drugs, adjuvants, which we will be talking about, should be used. And to maintain freedom of pain, drugs should be given by the clock, that is every 3 to 6 hours rather than on demand. This quote is very, very timely, very, very appropriate, and very applicable to a lot of other disease entities, such as orthopedic pain, chronic pain. So the Orthopedic Association just came out with the guidelines for chronic back pain, and one of the things they did talk about is that opioids are not the first, should not be the first line. And actually this is very consistent with the World Health Organization for cancer pain. We should be doing other modalities as opposed to giving opioids. The other very key point to this quote is that when we give pain medication, we never want to give medication as needed, because they find that in terms of controlling pain, it's not well controlled that way. It's better to be offering pain medication prior to the patient getting to an extreme pain. So again, I would refer you to use this quote when you're caring for your patients and remember it. Even though it's difficult as a provider sometimes to be able to assess somebody, the level of somebody's pain, one must remember as a provider that pain is subjective, and two different patients with the same etiology and the same disease or physiological problem could rate their pain differently. We find that there's difference in gender. Sometimes men have more difficulty with pain, and also different ethnicities express pain differently. So one must be very aware of the patient population that we take care of, but we do indeed, in that term saying subjective, that we do have to recognize what the patient says their pain is, it actually is, and we have to accordingly address their pain. There are different assessment tools that are used for pain, but it's very important that you do use a pain scale and that you evaluate the pain. So these are some of the pain scales that we use in practice. Some facilities use 0 to 5, as 5 being the highest. Most use 0 to 10, and very important that you find out what a patient's pain is prior to any modality. And the biggest thing that was actually referenced on the previous slide is that you have to assess the patient and evaluate that indeed whatever treatment you give them and whatever medication you give them that is indeed effective, or you're really not completing the circle. So really important that you get their pain level, you implement whatever modality, like in the emergency department, many times we're giving people pain medication, and it's most important that we go back and assess if indeed that's helpful. In a practice, in my practice, if I have somebody who's on chronic pain medication and they come for a renewal, I have to really assess and evaluate whether that's effective or not. By asking the scale and also speaking to them about, a lot of it also has to do with quality of life. It's really, the pain is really affecting the quality of life, but these scales are most helpful. So most of you might be familiar with the smiley face and frown scale. Very useful in pediatric population, but also most helpful in patients who don't speak English, English speaking patients, patients who might be nonverbal. Very important that they can point to what their pain is using the smiley face. So you'll see that used quite often, and it's very, very helpful in assessing pain. Very important that when you're assessing patients' pain, that you recognize that there are sometimes patients, particularly patients who have been on chronic pain for a while, can get a tolerance to the pain medication or a cross tolerance. So sometimes you have to be able to, and this goes really back to your assessing and reassessing patients, that it's really important that you see that they indeed are getting relief from it, because you might have to change your modality. As prescribers, the most important thing with any medication we give, particularly pain medication, that we want to have our benefits outweigh our risks. So we want to make sure that especially with dealing with medications that are highly addictive, we want to make sure that are they indeed beneficial, and that we're maximizing the efficacy, the pharmacological action of the medication, while minimizing the adverse effects. Every medication has an adverse effect, so we have to really be aware of that. And the third part of that is that it's really important that we educate our patients, their family, particularly patients who are going to be on pain medication for a long time, of all the adverse effects, of the potential risk factors, the risk factor for addiction, for tolerance. If we don't do that, we're actually not doing our job as providers. So education is very important. When we're prescribing medications, particularly pain medication, there are 3 vulnerable populations that we always must take special consideration with: the elderly, children, and pregnant women. In the elderly patients, but from normal physiological changes, they have a heightened sensitivity to medications. And the reason for that is that medications usually are given in the GI tract, which in pharmacology, the saying is, if the gut works, use it. The normal physiological changes in the gastrointestinal tract actually diminish the absorption of drugs in the older adult. They have less hydrochloric acid, they have less mucosal layer, they have less gastroparesis, or the movement of drugs through the GI tract. As a result, it predisposes them for the drugs staying in the system and more toxicity. After drugs are absorbed, they go distributed through the circulatory system, and because of normal changes in the cardiovascular system, such as atherosclerosis, such as decreased contractility of the heart, drugs are not readily distributed to the site of action and stay in the body. After drugs are distributed to the site of action, the end products of the drug are given to the liver to be metabolized and then excreted. Unfortunately, the liver itself is affected by just normal aging. So the portal circulation is changed, and as a result, medications are not metabolized, the end products are not metabolized. Lastly, drugs are excreted through the kidneys. And our kidneys, from normal aging, we have less nephrons, which are the operating cell of the kidneys. We don't filter as well. So all of these contributing factors, and this is without even disease pathology, actually predisposes older adults to drug-drug interactions and sensitivity to drugs. Some of the misnomers about older adults with medication, and I just want to qualify one other thing. Most elderly take between 4.5 to 5 prescription drugs a day, and that's besides all the over-the-counter medications and supplements they take. So you can see that that can actually cause a thing called polypharmacy, multiple medications by multiple prescribers. One of the misnomers that unfortunately is seen is that many providers feel that the elderly don't feel pain, that their nerve endings are stunted, that they don't feel pain, and that's absolutely untrue. But what we do have to be concerned about is that because of all those physiological changes, they're much more sensitive to when you're going to be prescribing pain medication to them. Some scenarios that you'd be dealing with is that if you have and I've had this happen when I prescribed in the emergency department, if you have a 93-year-old that fractured her wrist, you know, you can't send her home without any pain medication. That would be cruel. However, you have to assess whether this person lives alone and they're taking narcotic medication. So you have to really look at benefits, risks again about what you're going to do. But older adults absolutely do feel pain. One of the things that was developed by the John Hartford Foundation for Geriatric Care in collaboration with gerontologists, pharmacologists, and some providers that take care of older adults is a criteria called the Beers criteria. What the Beers criteria does is identify drugs that are precautionary for patients over the age of 65. And now you can kind of laugh about that because you think of the quality of some 65-year-olds now are very healthy, they don't have any comorbidities, they don't take any medications, but they felt that 65 was the time where these physiological changes that I addressed start to come into play. So the website that I'd like you to look at talks about the Beers criteria and some strategies to be able to look at what medications to prescribe or be cautious about prescribing. Most of them are your pain medications. Some of them are cardiac medications because older adults have some reaction to some of those medications. And it's really very important that you know what the Beers criteria is. However, after looking at the website, I want you to bear in mind that it really is prescriber consideration and decision what you're going to prescribe for your patients, because again, not all 65-year-olds are the same as, or some 85-year-olds. So you really have to make it patient-specific when you prescribe to this vulnerable population. In regard to children, it's very important, particularly that they can elicit where their pain is quite often, especially if they're, you know, toddlers, infants, even young children can't always tell you where their pain is. So it's very important that you do a complete physical assessment, looking for grimacing or, you know, any guarding of any limbs or extremities. So very important that you do a physical assessment on them. This also pertains to people who are nonverbal. I once had a patient in the emergency department that was seen earlier in the week after a fall, and the caregiver noticed that he had was not using his arm. So they had x-rayed his forearm, his radius and ulna, and did not see any fracture and put him in a splint and sent him home. About 10 days later, they came back because he still wasn't using his arm, and they noticed a bruise on his shoulder area. And when we x-rayed his humerus, we found that he had a very, very complex fracture of the humerus. And he was walking around with this for like almost 2 weeks. Because he was nonverbal, what really should have been done is that the whole limb should have been x-rayed. and it was really sad for this patient, but we were able to get him splinted and correctly treated. And this also is very true with children. You also have to realize that you do have to give children pain medication. We very often, when we have to treat a displaced fracture, we sometimes have to give them Versed or medication to twilight to be able to place the displaced fracture. But then they need to have some pain medication. Tylenol and ibuprofen after age 6 months is okay, but sometimes we have to give them a little bit more pain medication. And we do find that actually Tylenol with codeine does work in limited amounts, but you do still have to consider their pain. With pregnancy, our main concern is what's beneficial to the mother and the fetus. One must always bear in mind that it's the mother's life that precedes the life of the fetus. So you have to do what's in best interest for the mother. Any medications that you're going to prescribe can cause fetal demise or deformities and so on. Usually it's from week 4 to week 18 that are the most critical times of fetal development. That's when most of the organs are being developed. So we really try not to prescribe any pain medication or any medications in that first trimester going into the second trimester. The first couple of weeks, actually, there aren't as many issues to fetal demise. And if you think about that, many women don't even know they're pregnant and they're drinking alcohol and taking medication and they don't really know. And statistically, they find that really doesn't have any issue with the fetus. But it's that critical time when the organs are being developed that one must be very particularly careful. That does not mean that you don't give pain medication to somebody who's pregnant. You just have to be really careful. We used to use the scale of B, C, D, and X as the categories of safety. Category B says that there's no issues to the fetus in animals, not in humans. Category C mentions that there can be demise to animal fetus, not human fetus. Category D is definitely there is issues with fetal demise in humans, and Category X is absolutely not recommended. However, in recent couple of months, the pediatric and OB people, obstetrical people have come out where they've gotten rid of the categories. They don't use B, C, D, and X anymore. They, if you look in your prescribing guide, like your electronic prescriber, like Hippocrates, it actually just talks about safety, so it's not as finite, which makes it very difficult. If you can see here, I have some of the medications that say category C, and that really is that you give it with care, pretty much with every pregnancy. So morphine, tramadol, codeine, you have to be really, really careful. Even Tylenol can be very, very dangerous, so you have to be really careful. So effective opioid prescribing is really dependent upon having a holistic approach. And a holistic approach, especially as advanced practice nurses, as we all know from our education, is that it's not just writing the prescription for the patient, it's also finding out whether, again, viewing and taking into view their ethnicity, their ability to afford the medication, what their lifestyle is like, what their psychosocial needs are, what their employment is, whether, you know, if they're if they handle heavy machinery. So that holistic approach is really, really important. I always tell my students in pharmacology, anybody can write a prescription for anybody, but what you do afterwards is very, very important. We discussed earlier that it's really important to monitor effectiveness, to be aware of addiction, and tolerance, and that's really, really important. So we have to make sure that we use effective strategies. Also, I think another thing that's really important is that how you decide what you're going to prescribe for people or whatever treatment you're going to do has to do with the ability of the person to function on a daily basis. So their ability to perform their activities of daily living. If it's really affecting their job, their sleep, their relationships, then it's something that you really need to take into, you have to really consider those before you decide what you're going to do with the patient. So listening, again, back to the history is really, really important. Some of the factors that need to be taken into consideration if the patient has any comorbidities, if they're diabetic, if they have neurogenic pain from diabetes, if they have cardiovascular disease, if they have respiratory problems, any other comorbid diseases will affect how well you're going to be able to control their pain. Age, we already talked about in those unique special considerations. Their gender, their employment status. So you really have to look at all the things that affect your prescribing opioids. The route that we consider of giving the medication really depends upon the severity of the medication or the pain and also the efficacy of the medication. So if you have somebody who's in acute pain, like we see a lot of times in the emergency department, we're going to give medications IV. Your patients with cancer, metastatic cancer, we're going to give it intravenously, sometimes continuously to the patient. We also have to consider many of these medications cause nausea and vomiting, so we have to realize that maybe we have to control that, and we have to decide whether they actually can take oral medication. You would always prefer to give oral medication, but sometimes you can't do that. We'll talk about a little bit that some medications are given through the skin transdermally. So your consideration actually looks at the severity of the medication, any of the contributory factors that the patient has, and how you want to distribute the medication. The class of analgesias that we're going to be discussing are opioids, or non-opioids, or NSAIDs, our adjuvant therapy, and our neuroleptics. Consistent with the WHO management of chronic pain, they recommend a 3-step approach to pain management. Okay, step 1 would be for mild pain, which would be aspirin, Tylenol, NSAIDs. Then we can go to more moderate pain, pain management, which would be tramadol, codeine, and then step 3 would be the opioids like morphine, DILAUDID, and so on. So we should not be going right to the stronger medications, and we should be going through a step approach. Let's take a look at this website of the WHO where it discusses the steps used to achieve proper analgesia. Opioid receptors work directly on the central nervous system, and the main opioid receptor is the receptor of mu. Mu actually depresses CNS perception of pain, and also causes a feeling. If you look in any prescribing guide, it actually says that morphine causes euphoria, which it absolutely does, and it also does unfortunate side effects is respiratory depression. So one must be very, very careful when prescribing morphine. Kappa, beta, and sigma are also contributory to pain management, but they're not as effective as the mu receptor. They, if you refer to the slides that you've been given in your packet, you can see how they contribute to some of the adverse effects from opioids. Morphine is the most common opioid that's prescribed for moderate to severe pain. It works right on the mu receptors, as we previously discussed, has a half-life of about 2 to 4 hours, and can be given in oral form, but is much more effective as given as an injectable. Some of the common adverse effects of morphine is urinary retention. So quite often you see that on patients who have been on a morphine drip or have been getting morphine post-operatively, and they have a catheter, and then you remove their Foley catheter, and then they're unable to urinate, and it's actually a result of the morphine suppressing the sphincter and the urinary bladder. The other issue is nausea and vomiting, so you need to anticipate that in your patients, that they will have possibly have nausea and vomiting from it, so you might have to medicate them for that. The more severe reaction to the morphine is respiratory depression, which can be quite profound. So you must make sure, particularly patients who have any respiratory or cardiovascular difficulties, that the chance of respiratory depression is very, very possible. And the other thing is that it is highly addictive. It is Schedule II, and it is addictive. One of the issues with opioids is we want to prevent, as providers, the chance of dependence and addiction. So we, as previously discussed, we have to be able to monitor and taper our dosaging as needed. Quite often, if you look at the current literature about drug dependence and substance abuse, it's quite often patients who've been prescribed narcotics for an orthopedic procedure or a surgical procedure, and they're given like 90 pills, and they only need 1 or 2, and then they have the medication there. And unfortunately, it's either taken by themselves or a family member and so on. So there's been measures nationally and within the state to make sure that we prescribe less medications or pills. So very important that when a patient is coming to you and asking for pain medication, when it's not consistent or congruent with the illness, it's very important that we become aware of that. Though conversely, sometimes patients who have surgery are afraid to take narcotics because of fear of addiction. Usually in short-term use, that doesn't happen. The state of Massachusetts has actually come up with, they'll only give patients a certain amount of medications, and New Jersey has just started doing that we can only prescribe for 5 days of narcotics with a patient initially. So there's more and more state and national regulation of this, and which is very, very important. But we also have to be cognizant of any addictive behavior with patients. I've had patients who, in the emergency room, who've actually come in and pretended to be somebody else to get narcotics. I've had some patients who came to me after seeing an orthopedic telling me that they didn't get any pain medication, and then hearing from their pharmacy that they just filled another prescription. We have a drug clearinghouse for narcotics that is a central location within the state that notifies us if patients are going to multiple pharmacies and so on. But our awareness is very, very important to see. If it's anything that seems atypical, it's really important to be aware of this. In referring to the chart that's posted here, it's a wonderful visual about how we can manage pain. The one line, the red line, talks about PRN medication. So we talked about giving medication intermittently. And as you can see, it kind of fluctuates between the pain, which is at the bottom of the screen, and the adverse effects of respiratory depression. So the risk of having respiratory depression, as you can see, spikes when you're giving intermittent pain, because you're giving a high dose that actually diminishes as time goes on. Pain relief also dips in between those scheduled dosages. A patient-controlled analgesia, which many of you have worked with, I'm sure, that's demonstrated there where you have it right in the middle. So your pain is controlled and you're not in the adverse effect range. Patient-controlled analgesia, as we all know, is used after surgery, where the patient gets a set amount of IV medication throughout whenever is needed, usually post-operatively, and then it's stopped. And the literature actually supports that patients who have patient-controlled analgesia afterwards need less narcotic pain medication, so their blood level is consistent. To give a fixed schedule, which is what we talked about and the WHO talks about, is that you have the patient within that range where they're not getting the peaks and valleys of pain and at risk for adverse reactions. So that supports, this chart actually supports why you would give a fixed schedule of pain medication. Codeine is a moderate narcotic, usually given for more mild to moderate pain, usually combined with Tylenol or Motrin. One of the things that has been done with the evolution or the literature being noticing that Tylenol has caused more kidney failure. We've reduced the dose of Tylenol in the Tylenol and codeine dose. The biggest adverse problem with codeine is constipation. It's not respiratory depression, it's constipation. So you have to bear that in mind if you're going to put that on, prescribe that medication for somebody, that you might have to have, increase the fiber, the fluid in their diet, maybe give them a stool softener. The other mild to moderate pain medications that are used that are controlled is your Vicodin, which is actually synthetic codeine, Stadol, Talwin, and Nubain. Even though a lot of institutions still don't use it, the literature does support for some specific situations they are still prescribed. And the last one is Suboxone. Suboxone is used for people who have substance abuse. Interestingly enough, nurse practitioners or advanced practice nurses cannot initially prescribe Suboxone. We can renew it, though our credentialing bodies have now come out with that if you take a certain module and certain education, you can prescribe Suboxone. But presently, we can only renew it because it's so highly addictive. Fentanyl is usually given either buccally in the cheek or mostly with patch. It's used for chronic pain, not used for acute pain. Biggest thing about fentanyl is that it has a 17-hour half-life, so it's got a long half-life, and you have to change the patches, usually daily. And the biggest issue is that most primary care providers, ED providers, do not prescribe fentanyl. Usually it's a pain management person that will prescribe it because it's highly addictive. What we're finding is that a lot of the medication that are being sold on the street now are laced with fentanyl, and that's why people are having so much overdose. So it's a really highly addictive medication. It should not be given with people who are under 110 pounds because it's too lethal. So it's usually prescribed by pain management, and usually primary care and ED people don't prescribe it. But you need to know that if your patients are on it. One must be familiar with the different equivalencies of fentanyl depending upon how it's being prescribed. So there are differences between buccal, oral, and transdermal in terms of dosaging. So one must be aware of if you're going to convert from one form to the other, you need to know what the equivalencies are. And in 2005, fentanyl went generic, so it's a little bit less costly for patients. DILAUDID is often given, it's another opioid. It's much more potent than morphine. Used a lot of times for post-op pain. Actually, we see it a lot in the emergency room with people who have sickle cell crisis. Patients who have sickle cell crisis because of the lack of oxygen. Morphine, they don't respond well to morphine, and they need high doses of DILAUDID. DILAUDID usually is given IM or IV. If it is given orally and prescribed orally, it can only be given in a couple of pills because it's so highly addictive. DEMEROL was formerly used quite often as a pain medication. Unfortunately, they found that the metabolites, end products of the DEMEROL cause toxicity. So it's been taken off a lot of formularies. It is sometimes used for procedural, prior to a procedure, and it also helps with pancreatitis for the sphincter of Oddi, but otherwise you won't see DEMEROL used anymore because of the toxicity that it causes. Oxycodone can be used pre-procedure, during a procedure, after a procedure for pain management. Half-life is about 3 to 4 hours. It is long-acting and oral. The biggest problem is that it is highly addictive. So this is the medication that you're seeing many people that are addicted to on the street after pain medication. And one of the things that the pharmacists and the drug companies realized was that the way it was originally formulated, that people got an instant release as soon as they took the medication, which made it the potential for addiction was really, really high. So as a result, in the last couple of years, they've reformulated it so they don't get that immediate high. It takes a lot longer to get that, to deter people from buying it on the street. I've had many patients addicted to oxycodone that they buy on the street, and it's really difficult to get them off of it. In your packet, this familiarizes you with the conversion factor of going from an IV to an oral form of the medication and to see what the equivalents are. So that's very important. If you have a patient who's on an injectable, you need to know what dose correlates to the oral, so you'll be able to prescribe it properly. Tramadol originally was prescribed for orthopedic injuries and was not controlled until about 1 or 2 years ago, and now it's Schedule 3. It binds to the mu receptors and is helpful for moderate pain. Most people have some neuro signs from it. They get headache and dizziness and so on. And I have to say, with my experience with tramadol, many patients, particularly opioid-seeking patients, are not happy when you give them tramadol, but it does help with orthopedic pain if you can get your patients to accept it. Particularly for neuroleptic pain, we find that the tricyclics, antidepressants, really help with neurogenic pain. But a class of drug we've been finding very effective in relieving neurogenic pain are the anti-seizure medications. Gabapentin, we also use Lyrica a lot, and that does help people with neurogenic pain. Sometimes there's an inflammatory process that's involved with pain, so that's where we use steroids. We might use some antihistamines sometimes to control pain. Antihistamines actually sometimes helpful with your older adults, that you can use those instead of opioids. Medications that aid in pain medication or can be adjunctive to the opioid prescriptions are our nonsteroidals, anti-inflammatories, your Motrin, and we find that naproxen works very, very well, particularly with orthopedic issues. You have to just be careful with people's liver and kidneys and their GI tract before you use NSAIDs. Toradol is a wonderful medication that we use in the emergency department quite often for renal calculi, for migraines, for a lot of times people with chronic back pain. We give it intravenously, and it's a wonderful anti-inflammatory that we can use. You do not, it can be given orally, but because of the side effects and GI side effects, that we don't usually send people home on it, but it's something that we can help. It really helps in those conditions. Some of the barriers to assessment that we previously talked about is underreporting by the patient, inaccurate reporting by the patient, and language barriers. So it's very important that we keep that in mind. One of the regulations, because of the incidence of substance abuse and inappropriate prescribing of opioids, is that the Federal Bureau of Medical Examiners has made sure that in documentation, which is so important, that we include our assessment, any diagnostic tests, any pertinent information that has to do with the patient and their pain request, that we periodically evaluate the patient's medication, that we include any alternative modalities. Many of my patients, I recommend yoga, meditation. We send them sometimes to pain management, but more importantly that they use some other modalities to be able to help them. And the important thing is that we have to document that. It's very important as providers that we are familiar with the federal regulations. I refer you to the website of the Federal Board of Medical Examiners to be able to look at some of the regulation. The FDA website is a very helpful website, but particularly one is a provider must be aware of what the regulations are in one's own state. You periodically as a provider will get information from the Department of Consumer Affairs, from the Attorney General about being a prescriber of opioids. One way of also keeping abreast of this is being involved in your New Jersey State Nurses Association and the Forum of Advanced Practice Nurses. And we really keep our members updated on any legislative changes and prescriptive changes. The New Jersey law about prescribing is a little bit detailed in terms of what your requirements are as a prescriber. I would refer you to the website to be able to look at the New Jersey Consumer Affairs for the detail. But once again, to reiterate, it's very important that one discusses and documents why the patient needs a medication, how it affects their life, any diagnostic tests that you've done, such as an MRI, X-rays that show any disease processes, what treatment you've done, particularly physical therapy, anything that's done besides opioid prescriptions, and then the evaluation of ongoing pain medication. So the state law also requires, as you previously reviewed in the prior module, that you have to keep your prescription or state mandated prescriptions, and that you have to have a collaborating physician to be able to write narcotic medications. That's in correlation with a joint protocol. New Jersey is one of the only, one of the states that do require a joint protocol. There are 23 states, however, in the United States where advanced practice nurses practice without, with full practice authority and don't need a collaborating physician. But in New Jersey right now, we have the bill proposed to eliminate the joint protocol, where the state of Connecticut, New York, Delaware, and Maryland have actually eliminated their joint protocol. The outcomes that have actually been in the literature have really made Medicare and other providers quite aware that states where nurse practitioners have full practice authority, the outcomes for patients are actually equal or above that of having a collaborating physician. So they're starting to look at that our efficiency is very good because we are holistic. But for prescribing purposes, you have to have a controlled drug substance number. You have to have a current DEA number, which has to be current. You have to fill out the prescription as demonstrated in the last module. If your date is incorrect, if anything is missing on the prescription, it will not be filled. So that's really, really important that you get comfortable with how to write medications for controlled substances. One thing I will really be emphatic about, and some physicians and providers do this, when you order your prescriptions, do not put your DEA number on the prescription. Don't have it printed on the prescription. Write it in each time, because often we've had patients who've taken prescribers' prescriptions, and if the DEA number is on there, they can get narcotics. So most of us choose not to put our DEA number, and we write it in. That's very, very important. So the state law requires that every 3 months we reevaluate patients who are on opioids, and what modalities we have done to either reduce the dosages, or what our plan is to have the patient stop taking the opioids. So we have to initially, which I did not mention previously, is we're supposed to have an informed consent with the patient. It can be a verbal consent, but you have to formulate a plan. And as we all know, that we want to have patients to be adherent, not compliant. A compliant patient takes the prescription we give them, and they're not an active part of their management. You want a patient to be adherent, so you have to talk to the patient and let them be an active participant in this plan. And you discuss the pros and cons. You have to discuss the potential for abuse. And every 3 months you have to absolutely document what modalities you're doing as a provider to be able to eliminate the patient being on the opioids. As prescribers in the state of New Jersey, we're only permitted, with the exception of patients who are on cancer patients or palliative care, to only prescribe 30 days of an opioid. Now, with the new law that just came into effect, with new patients, we're only permitted to prescribe 5 days worth of medication. So it's going to be changing. You all will be required to go on to the clearinghouse and register. So this way your prescriptions are monitored for patients, and you'll be able to, it will be monitored how well you're actually reevaluating your patients. But currently it is 30 days. So patients who are on any pain medication do have to come and see you every 30 days. That's also true on patients who are on ADHD medication because of the stimulants. They have to come every 30 days to get their medication renewed. Another exception to that is if a patient has an implantable infusion pump for pain medication. They also can get more than a 30-day supply. One exception to the 30-day rule is that patients who have implantable pumps can get a 90-day supply. And a new amendment to this law came out recently where physicians, particularly with patients who are cancer patients or palliative care, they can write 3 different prescriptions for 30 days. So the patient, and they have to document it appropriately, but they would write it for 1 month and then they can date it for 2 other consecutive months after that. Unfortunately, advanced practice nurses were not listed on that law. Our lobbyist informed me that it just that they forgot to put us on the law. So the bill is being amended that we'll be able to do that too. And this is really important to nurse practitioners who work with oncology patients. Now I'd like to discuss a case study of somebody with back pain. Quite often, a lot of the patients that come to you requiring or requesting opioids are patients with back pain. And consistent with the WHO STEP approach and the new orthopedic guidelines that opioids should not be the first line of treatment, I'd like to discuss this patient and how possibly you would address some of his complaints. He's a 64-year-old male who's had chronic back pain, takes Tylenol as needed for pain, and takes ibuprofen when the pain gets worse. His pain has been worsening. He's an artist, so he does do a lot of standing. He feels that his pain is starting to affect his activities of daily living. In terms of his physical exam, he just has some mild, non-radicular pain on the outside of his spine, not directly spinal pressure, which is usually very typical of people with back strain. So he doesn't have any neurological symptoms. He doesn't have any pain radiating down his leg. He just has back pain that is really kind of just troubling and distressing to him. His past medical history is uneventful except for some hyperlipidemia and hypertension, no history of cancer, no history of injury. So let's discuss how would we maybe, we do have to address that his activities of daily living have changed, but do we really want to introduce an opioid at this point? Quite often, providers will send patients for diagnostic tests, an x-ray of the spine. One has to be a little bit cautious of ordering diagnostic tests that are not necessary. Most people, especially somebody who's 64 years old, will have degenerative joint disease in any of their limbs, particularly in their spine, especially someone as this patient who does a lot of standing. He is an artist, so he probably lifts canvases and so on. So usually the guidelines is that you would do an x-ray only if there was an injury or he had direct spinal tenderness. To have musculoskeletal paraspinal pain usually is muscular, so you're not going to see that on an x-ray. You can do it, some insurance companies do require it if you are going to go further in your diagnostic tests, but it wouldn't be the first thing that I would do for this patient. If indeed he did have radicular pain where he's having numbness and tingling and needs an MRI, usually you do have to do a baseline x-ray. But in this case, I probably would not do an x-ray on this patient. Some of the modalities I might prescribe for him or recommend for him would be physical therapy, some stretching, and maybe some yoga. People often ask about going to the chiropractor. One must be really cautious about that until you really know physiologically what's going on with the person. So I would do stretching, yoga, physical therapy if needed. And I probably would not be prescribing opioids for this patient because it really isn't indicated. So one of the things we have to do in summary is to ask our patients the questions. As I previously said, getting the appropriate history and asking the correct questions would be really, really helpful in determining what the etiology is, what the pathology is, with the type of pain, which will help you to decide what appropriate treatment you're going to do for this patient. Believe the patient. Remember, pain is subjective. It's really important that we know that the patient indeed is having pain. It's often difficult because sometimes I'll see patients come into the emergency department who tell me their pain is a 10 and then you see them laughing, and it's difficult, but when you do assess them, you do see that they are in pain. People deal with pain differently. People have different tolerance for pain, so you really do have to accept that. Choose the correct modality. Be aware of that, the WHO STEP approach, that you really want to start low and go up as needed. Deliver your treatment in timely, logical fashion, and always empower the patient to be an active part and their family. If the patient's nonverbal, like our patient that I talked about who lived in the assisted living, or a child, or an elderly person who's got cognitive problems, you have to empower them, and you might have to empower somebody else in their family. But it's really important that they're an active participant in this plan, and you find you'll get better outcomes with that. I do hope that this module has been informative for you and will help you with as you moved on to be a prescriber. We do ask that you do visit all the websites that we have posted and complete the requirements for this module before moving on to the next one, and I thank you very much.